Good morning. Today we are going to revise the topic red and white lesions of oral cavity. Okay, we'll have multiple choice questions when we will discuss this topic briefly. So the first question is oral Lycanide reactions. What does it mean? It includes what and what? Like it includes Lycanide contact reactions, lichen planus or Lycanide drug eruptions or all the above. The answer is means oral Lycanide reactions means what? Mean it includes all these reactions. The answer is all the above. Next question is mainstay of treatment for oral lichen planus is it what is the main treatment modality? What is the first thing we have to do once we are confirming it as a lichen planus? Sometimes even this treatment is needed to conclude the diagnosis. If it is responding to the particular treatment, we can confirm it as a lichen planus only. What is the mainstay of treatment is topical steroids are giving tacrolimus systemically or cyclosporin systemically or topical anesthetics. What is the mainstay of treatment for oral lichen planus? That is nothing but topical steroids are given as mainstay of treatment, and if the lesion is responding, if the lesion is healing with these topical steroids, to some extent at least we can confirm this as the lichen planus, and we can proceed with, if at all it is very severe, we can even proceed with the systemic drugs. Next question is oral submucous fibrosis is caused by what? How it is caused? The name itself indicates, we can think in that way. It is due to altered collagen metabolism or increased fibrosis or erica node chewing or all the above. So the name indicates fibrosis and it is submucous and it is in the oral cavity. So what is the answer? The answer will be all the above will be seen in the oral submucous fibrosis. There is some alteration in the collagen metabolism which leads to the increased fibrosis. All this occurs because of the chronic erica nut chewing habit. It affects the collagen metabolism, that erica nut component. Next question is hairy leukoplakia. Yeah, so okay, hairy leukoplakia is a oral lesion. It is most commonly presented on which part of the oral mucosa? It is mostly common on dorsum of the tongue, buccal mucosa, palate or lateral border of the tongue. Where it is most commonly seen? Answer is it is most commonly or exclusively we can say it is seen on the lateral border of the tongue. Next question is prevalence of candida infection in oral cavity, that is candidiasis, as normal flora. That is prevalence of candida, not infection. We are discussing about the prevalence of candida albicans, that fungus in oral cavity as normal flora. It is present as normal flora in more in blood group O individuals or in denture wearers or xerostomia, that is dry mouth patients, or all the above. All these patients. In which group of these patients the candida is more prevalent as a normal flora without causing any infection? That is in all these patients, with the patients with dry mouth, denture wearers and blood group O individuals who have the blood group as O. These patients will have the candida in more number and as normal flora without causing any infection. Next is white appearance of oral mucosa can be because of. Is it because of increased vascularization, accumulation of intra or extracellular fluid, raised mucosa compared to the adjacent mucosa, or all the above? What is the reason for the white lesions of the oral mucosa? The answer is due to the accumulation of intra or extracellular fluid. It is one of the reasons. There are many other reasons for the white lesions, like increased keratinization is also one among them. So here the answer is accumulation of intra or extracellular fluid. Next, pseudomembrane formed in candida infections is comprised of. In candida infections, you will see some pseudomembranous like layer on the lesions. Is it because of bacteria and saliva, clotted blood and epithelial debris, or fungal organisms and cellular debris, or all the above? So what is it? It is caused by candida infection. Obviously, it will be fungal organisms will be present, that is candida albicans, and also the destroyed tissue, that is cellular debris, will be present in the pseudomembrane. Next question is atrophic epithelium appears clinically as. What is atrophic epithelium? How it appears? Is it will it appear as white lesion or red lesion or red and white lesion or none of the above? How it appears? If the epithelium is atrophied, it appears as red lesion. Nothing but there is a layer of epithelial cells is destroyed. So that we'll see the underlying connective tissue with more vascularity, and it appears as red lesion. Next, again a question on hairy leukoplakia. Hairy leukoplakia is strongly associated with following infection. How it is caused? What is the reason for the appearance of hairy leukoplakia in the mouth? Is it because of Candida infection or Epstein-Barr virus infection, human papilloma virus infection, that is HPV infection, or both A and B? That is Candida infection and Epstein-Barr virus infection will lead to hairy leukoplakia. So what is the answer? The answer is it is due to Epstein-Barr virus infection and is most commonly seen in HIV positive patients. Next, following is not a criteria for epithelial dysplasia. Which of the following is not considered as one of the sign of epithelial dysplastic change? Increased nuclear to cytoplasmic ratio, loss of polarity in the basal cells, loss of rete ridges, or loss of intercellular adherence, which is not a criteria for dysplasia, not a dysplastic change. That is, loss of intercellular adherence is not a criteria for dysplasia, but it is seen in like pemphigus patients. Clinically, oral lichen planus can manifest as any of the following, except oral lichen planus can appear as ulcerative, vesicular, verrucous, or reticular, which is not present clinically as lichen planus. Like ulcerative form is not seen, or vesicular, or verrucous, or reticular. Among this, one is not a manifestation of lichen planus clinically. That is, verrucous form is not seen. Okay. Which of the following manifests as only white lesion in the oral cavity? Oral lichen planus, only white lesion, systemic lupus erythematosus, hairy leukoplakia, or pemphigus. Which of these will manifest only as white lesion in the oral cavity? The answer is hairy leukoplakia, because oral lichen planus can be atrophic and red appears red. Even systemic lupus erythematosus will have a red component, and pemphigus will have the ulcerative component also. Next question. Oral examination includes all of the following except, so when we are doing clinical examination of the oral mucosa, we will observe for the alteration in any color of the mucosa, temperature of the mucosa, surface texture of the mucosa, or any bleeding points, which is not seen clinically of the oral mucosa especially. That is, temperature of the mucosa we cannot examine because of the continuous flow of saliva, the temperature is not maintained in the oral cavity. We cannot conclude it as the body temperature. So it is of no use if we are correctly checking for the temperature of the mucosa. Next is hairy leukoplakia. Again a question on hairy leukoplakia. We discussed it appears mainly on the lateral border of the tongue, and it is because of the Epstein-Barr virus infection. And this question is, what is hairy leukoplakia? It is an infectious condition, precancerous lesion or precancerous condition, or is it caused by local trauma? So what is it? As we discussed, it is caused by Epstein-Barr virus infection, and it is most commonly presented in patients with HIV infection. So it is an infectious condition. Which of the following is not caused by Candida? Okay, antibiotic sore mouth, kissing lesions, fever blisters, or angular cheilitis, which is not a manifestation of Candida infection. It is fever blisters. It is caused by herpes virus. Okay. In etiopathogenesis of oral submucous fibrosis, as we discussed, it is because of the habit and all. Increased fibrosis is due to, what is the reason for the increased fibrosis? We discussed it is due to the alteration in the collagen metabolism. So again, what is the reason for the alteration in the collagen metabolism? Is it arachidonic acid, acetylcholine, ericoline, or all the above? So what is the main thing? The answer is ericoline, that is present in the erica nut. Because of that erica nut chewing only, this condition is caused, oral submucous fibrosis. So answer is C. Next, clinical presentation of lichen planus depends on, what is the different criteria which will decide the how it is presented clinically. It will depend on patient's geographic area, in the in which country or which continent they are living, or site of involvement, like is it buccal mucosa, gingiva, palate, or which part of the mucosa is involved, and degree of inflammation or genetic defect. So how the clinical presentation depends on what aspect? It mainly depends on the degree of inflammation, that is inflammatory changes seen in the lichen planus. If it is severe, we will see it as a erythematous form like ulcerative. If it is mild, we'll see it as just white lesion. So it according to the degree of inflammation, it will present clinically. Which of the following is an infectious manifestation of oral mucosa? Means among this, which is an infectious condition like say lesion? Is the leukoplakia, erythroplakia, lichen planus or hairy leukoplakia? Again, we discussed no, that is because of Epstein-Barr virus infection we are seeing hairy leukoplakia. So this is the only thing which is an infectious manifestation. Other three are like precancerous lesions or conditions or like red and white lesions. That's it. Next, a white lesion of oral mucosa is caused by hyperkeratosis. That is, increased keratosis will lead to the white lesion. This statement is not true in case of frictional keratosis, leukoplakia, leukoedema, or oral lichen planus. In all these lesions, we are seeing the white lesion, but in one of these, hyperkeratosis is not the reason for the white appearance of the mucosa. What is that? The answer is leukoedema. In this, there is increase in the intracellular fluid accumulation that leads to the paleness of the mucosa. We consider it as white lesion. Next is chlorhexidine solution is not suggested to soak dentures in case of denture stomatitis. Why? Justify the statement. Because it discolors the denture, because it counteracts the effects of nystatin used to treat the denture stomatitis, or both A and B, or none of the above. What is the reason? It is both A and B. It discolors the denture, and also the nystatin which is given into the to treat the denture stomatitis in the patient, it also counteracts the effects of nystatin. The chlorhexidine will affect the effects of nystatin. So we are not going to advise the patient to soak the dentures in chlorhexidine solution. Candida associated lesions refer to. What does it mean? It is it refers to denture stomatitis. It is caused by candida and bacteria, and median rhamboid glossitis are all there. So when a lesion occurs as a denture stomatitis or median rhomboid glossitis, here there is also candida infection and also associated with bacterial infection. Means like both the infections will be there and they will manifest as denture stomatitis in case of denture wearers or sometimes as a median rhomboid glossitis. Those conditions are referred to as not candidal infections. They are referred to as the candida associated lesions. Means because of the candidal prevalence is increased and also there is superficial like superimposed bacterial infection also. In those cases only they will manifest like this. They are referred to as the candida associated lesions. So, leukoedema is the what is the characteristics of leukoedema again? So, okay, disappears on stretching of the oral mucosa. It is a genetic disorder. It is a red and white lesion or all the above. So, what is the answer? We discussed about this leukoedema. It disappears on stretching of oral mucosa is the correct point about leukoedema. Not it is not a red and white lesion and it is not a genetic disorder. Reticular lichen planus is characterized by hyperkeratosis, mild underlying inflammation, fine white lines, or all the above. So what do you mean by only reticular we are discussing here? So only reticular lichen planus is present clinically means there is hyperkeratosis, there is mild underlying inflammation. If the inflammation is more, you will see more of like erythematous ulcerative form, and also it appears as fine white lines. So that is referred to as the reticular lichen planus. Following are seen in initial course of oral submucous fibrosis. Initially, what changes will occur? Atrophic epithelium is seen, vesicles will be formed on the mucosa, petechiae also seen, all the above. So, what are the all these will be seen in the initial stages of oral submucous fibrosis. So, answer is all the above. Next question is following is not a variant of leukoplakia. So we have discussed leukoplakia will manifest again as many clinical forms. Among this which is not a variant. Hairy leukoplakia is not a variant of leukoplakia or speckled leukoplakia, verrucous leukoplakia or erythroleukoplakia. Among this which is not a variant of leukoplakia. It is hairy leukoplakia. Again we discussed it is an infectious condition present in HIV positive patients. Next question is differential diagnosis of oral lichen planus includes discoid lupus erythematosus because oral lichen planus is a red and white lesion or completely white lesion. So we need to include in the differential all the white lesions and also the all red and white lesions will be included in the differential diagnosis of lichen planus. Discoid lupus erythematosus, lichenoid reactions, leukoplegia, or all the above? The answer is like all the above is the answer. Which of the following is not a feature of lichen planus? Nikolsky's sign, Koebner phenomena, necrosis of basal cell layer, or both A and B? Which is not a feature of lichen planus? It is Koebner phenomena. Prognosis of early submucous fibrosis depends mainly on nutritional supplements, corticosteroid therapy, cessation of chewing habits, or surgical. So it is early oral submucous fibrosis we are discussing. The prognosis depends mainly on the cessation of the habits is more important in these patients if the like it is manifesting, we are diagnosing it in the early stages. So patient should be properly educated and we should explain him about the cessation of the habits, and so that we can stop the prognosis of these lesions. Next question is, reverse smoking of chutta leads to what? Erythroleukoplakia of palate, speculi of palate, erythroplakia of the palate, or leukoplakia of palate. What does it like results in what? Reverse smoking, that is mainly affects the palate. How it manifests clinically? As erythroplakia is the common presentation of reverse smoking patients. Erythroplakia of palate. So this is about the red and white lesions. So we discussed many questions in this topic, and according to the questions you can go in deep about that particular topic and you can revise the topic. Thank you. Thanks for watching, and please subscribe and follow our channel. Thank you.